Right. Well, good afternoon, everyone, and welcome. It's great to see you all here at our AD-RCMAR Professional Development Series. This is a series that we hold monthly, and we're really excited today to have two outstanding guest presenters, Dr. Kerry Greene and Dr. Michelle Carlson. And want to welcome them and welcome everyone, particularly a special welcome to two of our new RCMAR scientists, Rachel Wu and Julie Boron. Really happy that they could both join us today. Roland Thorpe, who would normally be here, who co-directs our AD-RCMAR Center, is giving a talk today in St. Louis at Washington University as we speak. So he will not be with us today, but he sends his warm regards. So we are really excited to have presentations today on two NIA-funded studies. They're really one-of-a-kind studies. The Woodlawn study and the Experience Core trial and some of the long-term outcomes of those studies. And last year we did a session on the active trial and the NHATS data set. And this session today is kind of patterned along the lines of that one last year. It really gives people an opportunity to hear about sort of the latest in the follow-up of these two studies, and also learn more about the data sets, give you opportunities to ask specific questions of our presenters and how you might become involved in these two really landmark studies. So the plan today is that we're going to have about 15-minute talks from each of our presenters, and then we will break into breakout rooms. You are free to float back and forth between the breakout rooms, and we'll spend maybe 15 minutes or so in the breakout rooms where you can have a chance to ask specific questions that you might not get the chance to ask otherwise, and then we will reconvene to wrap up the session at the end of the hour. I think without further ado, I'm going to go ahead and introduce both speakers first, and then I think Dr. Greene is going to go first, followed by Dr. Carlson. So Dr. Kerry Greene is a professor in the Department of Behavioral and Community Health at the School of Public Health at University of Maryland College Park. She's also director of the Behavioral and Community Health Undergraduate Honors Program. She received her master's degree in the Department of Human Development at Maryland, and her PhD right here at Hopkins from the Department of Health Policy Management in the Bloomberg School. She is a prevention scientist. Her work concentrates on improving the health and well-being of disadvantaged populations, and her research particularly focuses on identifying the causes of adverse outcomes over the life course among urban African Americans, including structural factors. And much of this work, as you'll hear today, has been involved with the Woodlawn study, which is a community cohort study that began in 1965. So a very long-running study, and includes data spanning 55 years of the cohort's lives, with funding over time from not only NIA, but also NIDA and NICHD. So welcome, Dr. Greene. It's great to have you with us today. And let me also introduce Dr. Michelle Carlson, who most of you, I think, know. Dr. Carlson is a professor in the Department of Mental Health at Johns Hopkins, and is a core faculty member in the Center on Aging and Health, and holds joint appointments in the Department of Epidemiology and the School of Nursing's Center on Innovative Care and Aging. She got her both her MA and PhD degrees in psychology at Duke University. And her work examines the relationship between modifiable lifestyle and vascular risk factors and risk for age-related cognitive and functional decline in Alzheimer's disease. And a lot of her work is expanded to include geospatial data, with the goal of identifying how environments can help or hinder the lives of older people. And she's led numerous large trials and observational studies. She is PI of the Hopkins PI of the Women's Health and Aging Study, the site PI of the GEMS, so the Ginkgo Evaluation of Memory Trial, and she is the PI of the Baltimore Experience Corps follow-up trial. So it's wonderful to have you two with us today, Dr. Carlson. And so with that, I think we will go ahead and get underway. And Kerry, if you can go ahead and share your screen.
There. Let me put it. Can everyone see it now? Does that work?
Yep, now you're in presentation mode, so it looks good.
Excellent. So
right,
thank you, everyone. I'm very excited to share this work with you all. I'm actually on sabbatical this year, and all I've been doing is working on this study. So it's really nice to share it with a new audience. So I'm going to primarily talk about what we have funded right now from the National Institute on Aging. It's understanding the aging process of urban African Americans across the life course. So it's really taking a life course focus and looking at early risk and protection. And we're focusing on both cognitive health, cognitive outcomes, and health, including mental health in midlife or older ages as it's spanning. So our current collaborators on the team is a number of folks at the University of Maryland: Elaine Doherty, who's trained as a criminologist; Brittany Bugby, who's running the study in terms of project management; Amelia Uria, again, who does a lot of longitudinal work. And then we have a lot of collaborators from Hopkins who worked over the years, but the current collaborators are George and Roland, who you know well, bringing us their expertise on aging and on cognitive health, which is not particularly our area. We've been funded over the years primarily by NIDA and really have focused on drug use and crime. So this is the first time we're really looking at in depth some cognitive outcomes with our cohort. And then recently retired Peg Ensminger, who's been instrumental in this study for many years, as well as some of you may know her husband, Shep Kellum, who actually was the founder of the study back in the 1960s. So my plan for today is to just give you a really broad overview of the study, explaining what the design was, the timeline, the aims, and then looking specifically at the data with really the goal of presenting some opportunities for collaboration. If this sparks your interest, if you think about some questions that might be of value to you, there's just so much more data than we can analyze. So we love collaborators. We love new perspectives, people coming from different backgrounds to really bring fresh eyes to this work. So this is the gray map is Illinois, for those familiar with that. And then on the right of that is Chicago. And then in red, you see Woodlawn. So Chicago, unlike some other cities like Baltimore and DC, has very defined community areas. Back when this study started, there were 76 of them. Now there's 77. But that red one shows Woodlawn, which is a single community in Chicago. And the Woodlawn Mental Health Center came to some researchers at the University of Chicago, Dr. Kellum being one of them, and said they really wanted to improve outcomes in school. So this actually began as an intervention program in first grade. The intervention proved not to be successful. It was actually sort of a breeding ground for developing these kind of school-based interventions, but it allowed us to collect some really in-depth data. So the focus at that time was on classroom adaptation and achievement. So a lot of the early data really focuses in on how well the kids were doing in first grade, and then with lots of follow-up data over time, which I'll show you. What's really interesting, I think, about this study compared to some other studies is not just its length, is that it included every kid in that neighborhood who was in school in first grade at the time. So all the public and private schools, there were of them. And actually we're in the field right now, and we were just talking to one of our participants, and he was saying, and one of our validation questions is, what school did you go to in first grade? And he's like, oh, actually I wasn't in a school. They just put a bunch of trailers in a parking lot at 66 and Woodlawn, and that was my school. It didn't have a name. And we're like, oh, we always thought that was the name of the school, not realizing it was not actually a formal school. It was, at the time to deal with overcrowding. So there's been periodic assessments over the life course. And as I said, right now we're doing an age 62 interview. So it's a really exciting study because we have this data that spans ages 6 and now to 62. So this gives you an overview of the various assessment points. This cohort was generally born in 1960. In first grade, the first point of intervention, mothers provided in-depth data on their children and also on their family life. And then teachers provided information on classroom behavior, on their achievement. We have clinicians who visited the classroom, who observed the children and did some ratings. So there's a wealth of data from first grade. And then at age 16, there was a follow-up with a smaller cohort. So it was just those who were in Chicago at that time, because that was a group in-person assessment with the teens, as well as the mothers who provided, again, some in-depth interview data. And then in young adulthood, we went back to the original cohort and did mostly in-person interviews with all the cohort members. And I say we, I hadn't yet actually joined this study. I joined this study in the next assessment, serving as project manager and helping run this midlife follow-up, which is age 42. And that and young adult have a lot of overlapping questions. So we were really thoughtful to be consistent, to look at change over time, and focus primarily on health, substance use, mental health, crime, those type of things, but also lots of data about neighborhood and social integration and family life. And then right now we're in the field. We just started collecting data in October, and we haven't been in touch with individuals in 20 years. So it is primarily a ton of detective work and a ton of reminding them that they participated in this study 20 years ago. And some of them actually we hadn't talked to in 50 some years, we hadn't been able to follow any of the follow-up points. And we've just did our second interview with someone we hadn't followed up with since first grade. So it's slow going, but we're in the field right now and collecting lots of great data. So in addition to the self-reported data from the cohort members, as well as their mothers and the teachers, we also have some official data. So we have lots of school testing data that we haven't looked at in depth really at all. And we think now that we're going to be focusing more on cognitive health and aging, that this will be really important to sort of understand the trajectory. We have lots of crime data. So we collected FBI records, Chicago Police Department records, and most recently, Illinois criminal justice system records. And it's a disadvantaged cohort. So it was a very segregated cohort at the time in Chicago. So there is some variability, but generally a low income area. And so about 60% of our males have been arrested and about 30% of our females have been arrested. So very high rates of interactions with the criminal justice system, which actually we started calling the criminal legal system. So I should update this, since there's been lots of talk of little justice in that system. And then we just collected, this past year. So through 2021, we have death records, and I'll show you a little bit more of the data and the outcomes around that. So our current aims are really to understand aging. We call this successful aging because we're most interested in understanding what are the aging experiences for this cohort, as a cohort that we expect is not well represented in national studies. We have a good amount of, incarcerated individuals, homeless individuals, so not a household-based population generally. We thought it would be really important to understand their perceptions of aging, as well as some more objective measures of aging. So we're looking at cognitive, physical functioning, social, mental health, to trying to put all those different measures together to understand these different aging profiles, and really focusing on the positive. We've heard that a bunch from our cohort members, that why are all your publications so negative and looking at these adverse outcomes? And we're like, that's our goal to prevent them. But we're really taking the perspective in this round of trying to look at success and what leads to resilience, what leads to success and longevity. And then for our second aim, we're looking at specific adversities over the life course that we think will influence aging. So we have a lot of data, as I said, from childhood and adolescence and young adulthood. So we have specific categories of adversity that we think are going to be most predictive in understanding adult outcomes, and that we will be testing those. And then again, we want to focus on protective factors and what might mitigate this early disadvantage or this early risk. So in terms of what we're collecting right now, how we're sort of looking to define successful aging, we have lots of different data. Our first pilot test was with cohort members was over 2 hours, and we thought, all right, we can't keep people on the phone for that long. So we've cut it down, but we were able to manage to maintain at least scales or items in all these categories, and are really excited to start doing some preliminary analyses. When we hit 200 interviews, we're going to start doing some psychometrics and start looking at some distributions that we have sort of peeked at it already. We have one question that asks, how old do you feel like you are? And we were really curious if people felt their age, if they felt younger or felt older. And so we've looked at some of the data to start. So we have successful aging, a number of questions on perception of aging, looking at life satisfaction, social isolation, mental health, which seems to be a big issue with cohort members. We're looking at leisure activities. We're using the telephone interview of cognitive status to get understanding of cognitive health. We are implementing the Cognitive Change Index, the SF-12 for physical health, the Pittsburgh Sleep Quality Index. We're assessing vision, hearing, and falls, chronic conditions, self-rated health, and generativity, among lots of other things, but these are ones I thought might be most interest to this group. And in terms of our earlier measures, these are all on our website. I'm going to highlight a few, but I took sort of a snapshot from our website. University of Maryland website format they use is not the most friendly. So if you do go to the website, which is woodlawn.umd.edu, which I'll put on their slide, you can click on instruments and you can see here that we have all the earlier instruments up there. The challenge is because they are for so long ago, they're not all searchable PDFs. So that is on our to-do list. Like if you're saying, oh, I wonder if they have, like someone recently asked me, I wonder if they have low birth weight. Well, you'd really have to look through that whole first grade interview because that one is not yet digitized. But this can at least give you a sense of what are some of the main constructs as well as some of the variables we've studied over time. And then our publications are here. So again, you can see what we've focused on in terms of research, which might spark interest, but also show you what we haven't looked at, which would be lots of gaps that, we're more than happy for other people to analyze that data. And so I highlighted here just some select early data that we thought might be of interest that we're going to be, looking at in terms of, the predicting successful aging. We have IQ tests for everyone who's in the public schools at the time, readiness tests, the teacher ratings of classroom adaptation, their grades. We've never looked at the 3rd grade and the 8th grade standardized testing, which we'll be interested in looking at now and predicting sort of cognitive performance at older ages. We have school records, we have self-reported educational achievement, parental education. We have lots of data on family composition and functioning. Lots of data on health, particularly substance use and crime, mental health, and then we have some on sort of structural issues, racism, racial socialization, neighborhood factors. We've geocoded all the data, so we have census data at each time point. And just to sort of point out, this started back in the 60s when measurement was just developing. So there's a lot of data we look at now, we think, oh, we could have measured that better instead of single items, multiple items. But we have really been able to find robust predictors from 1st grade of, outcomes into the 40s, and now we're hoping into the 60s. And what we've primarily been doing over the past year or two is focusing on our new mortality data. So our last interview data is just about 20 years old, and the journals seem to, we have a hard time sort of publishing this data now. We've published a lot on it, and we sort of get the feedback that, well, is it really relevant for now, which we make the case, but we've really turned our energy to analyzing our new mortality data. We know there's major disparities in mortality for African Americans, but also for certain neighborhoods. And so this is a more recent map of Chicago, which shows life expectancy and how it varies tremendously, even in neighborhoods that border one another. And Woodlawn, you can kind of see, is that little blue one in the middle of a sea of red on the coast on the lake. But most of our participants didn't stay in Woodlawn. Woodlawn's actually sort of had some a lot of transition there. It borders on the University of Chicago, and there's been a lot of construction, a lot of empty. Participants have primarily moved out of Woodlawn, but have stayed in sort of surrounding neighborhoods. And our most recent assessment, we're finding about 60% are in the Chicago area. And the primary data we're using from these mortality records collected from the National Death Index is looking at age and date of death, looking at cause of death. And then also we have sort of the geographic distribution of where these deaths are occurring. So just to give you a sense of, what we can do with this data when we're taking this life course perspective, we put this chart in one of our recent publications we just submitted looking at some life course predictors, and that one's really focusing on adversity over the life course and looking at mortality. after our last interview. But what you can see from this is that physical illness was not a primary cause of mortality early in life as expected, and that's become, after age 50, the vast majority of deaths are related to physical illness. These are primarily cancer and heart disease is what we're finding in this cohort. And then we see, violent deaths, which were very prominent before age 30. These deaths have gone down significantly. And then interestingly, drug and alcohol related deaths have sort of varied over time. We expected these numbers to go down, but we're really seeing some long-term consequences of early significant drug use, as well as some continued issues with overdose and such. So lots of great data. We have just really started getting into this. We haven't yet looked at, predictors of different causes of death, and that's sort of on the horizon with our planned analyses. So this is where we are right now in terms of what we're doing and what we're planning to do. We're really interested in looking at sex differences in mortality. The papers we've written so far, we've not sort of drilled down to that level. And we do think because of differential adversities experienced by men, different power structures between men and women, that we think that we could get, much stronger predictive models if we can stratify by sex or look at sex interactions. We started writing a paper on mental health, looking at depression and substance use seem to be the two most powerful predictors of mortality for this Woodlawn cohort. With in that one, we actually did find some sex interactions, with substance use being a strong predictor for the women, but not for the males, with depression being a strong predictor for males. So we're trying to disentangle some of those associations a little more, and we'll be writing that up. We have 2 papers right now under review. It's interesting when we run these mortality analyses, we put lots of variables in there unadjusted and they're significant. And as soon as we put in offending, everything else goes away. It's by far the most powerful predictor of mortality in the Woodlawn cohort. And that we're defining offending in that as arrests. And we're trying to really understand better if it is the arrests that's leading to the mortality, if it's the interactions with the criminal legal system that's leading to mortality, if it's the criminal lifestyle, sort of the behavior that's leading to it. So that's where we are right now with that, but we were surprised at how powerful a predictor that variable has been for this cohort. And then the second paper is really looking at patterns of disadvantage. So we're looking at family disadvantage in terms of poverty. We're looking at neighborhood disadvantage in terms of and what we're calculating is a neighborhood disadvantage index based on census data over time and individuals moving into better and worse neighborhoods. Both of those are, significant predictors of mortality. And in that paper, we're looking at some buffers. So we're looking at education as the ability to mitigate some of that early risk. And in fact, actually found that the education just seems to advantage the more advantaged, that it did not seem to affect at all those who grew up poor. So even if you were poor and had higher education, your mortality risk was no better or no worse than those who were not poor and didn't have education. So we're hoping to understand sort of better some of these protective factors. What we found does seem to buffer some of that early poverty is social role involvement. So we looked at parenting and marriage, church attendance, organizational attendance, and employment. And when we put together that and create a social integration index, that does seem to buffer some of the effects of early poverty. And then in terms of our next steps this summer, we're going to start doing some preliminary analyses with our data. As I mentioned, since it's been 20 years since we contacted cohort members, it's been quite slow going in terms of finding them and conducting interviews. So we expect to be in the field for at least through the end of this year. I think probably another year before we have all the new data on aging and the age 62 outcomes. So we'll be doing some preliminary analyses to start, just to look at the psychometrics of these and to start trying to understand how they might intercorrelate with one another. And once we have that data cleaned and ready to go, some of the main things we'll be focusing in on are sort of social networks and social integration, coping resources, and then looking at life course adversity. So in the grant, we define that as chronic strain, specific trauma, and then life events. And right now what we're working on is a qualitative data collection grant. So even though we've been in these cohort members' lives for 55 years. All the data that's been collected on them is quantitative, and we keep hearing interesting stories about their lives and things that we know our interviews are not collecting. So we're planning to do it's actually a mixed methods grant to combine our quantitative data with some newly collected qualitative data to really drill in on the aging experience, and particularly around social relationships as they relate to aging. So that was a quick overview of the Woodlawn study. I hope that gives you a sense of the opportunities for you if you're interested in looking more at these data. And I am more than happy in our breakout room to talk about specific measures or research questions we have, or past individuals who've worked on these and sort of how that works. So thank you for listening and your interest in this study.
Kerry, thanks so much. That was really a terrific talk, and what an amazing study and data set. Thank you so much. We are going to have lots of questions during the breakout sessions, I'm sure. Maybe there's time for one quick question or comment before we turn to our next presentation. Does anyone have a quick comment or question, Dr. Greene? Joe notes in the chat that mixed methods important. Yes, absolutely.
We're very excited. Yeah, we've had so many conversations with cohort members, but we're really excited to do like a real systematic qualitative assessment of them. So we hope it'll get funded. We're submitting it in June, so we'll see.
Yeah, because some of the things you're talking about, I'm wondering, gee, did anybody talk to them about it, right? I mean, if you discover things sort of, anecdotally, but then there's no really systematic way where you've sampled, an informative sample, et cetera. But things like successful aging, I'm hearing you say that, and I'm thinking, did anybody ask them what they thought successful aging was?
Yeah, and I think that's sort of the controversy in literature right now, is there's lots of different ways that individuals have defined successful aging, and we're not sure in reviewing them how well they apply to this population, because they're a population with a lot of chronic conditions and a lot of pain. So on paper, you would say they don't look like they're aging successfully. But I think, if they're functioning well and engaging in activities and they feel good, then that's not going to matter. So that's what our real goal is, to try to understand that in a more nuanced way.
Great. Well, thank you very much. More to follow. Michelle, I think we'll turn next to you. Thanks again, Kerry. And Michelle, if you can share your slides, it'd be great.
Going to unmute myself. So hopefully everybody can see that, and I'll go ahead and I'll see if, let's see, just to kind of give you an overview, this is the title, and there are 2 links to the my email address and a website that also gives you a bigger picture view of the Experience Core as well as Studies Nested. And it also lists all of our research publications on Experience Core, which are numerous. There are over 20 publications on the Experience Core, both the larger trial and the nested brain health studies. So really proud of our ongoing productivity in this particular study for the original trial that George led. So from here, I just want to orient us to why we care about this topic of Experience Core. And it started really in, I won't give you a long history given the time, but it really started in 1995 with a Civic Ventures collaboration. So it's always been community research based from its launch. Experience Core was coined by Eric Gardner, I forget his first name, but he coined this term, and it really stuck for us. And so as we did this, we really didn't have the literature behind us to support the work in the way we do fast forward 25, 30 years later. And what we know today, based on, for example, the Livingstone Review article, is that modifiable risk factors for dementias of aging have become predominant in the field, given a long history of failed pharmacologic and genetic modifiability trials. So we've become popular. We were patient and we were doing this work, but at the time that we started, I don't think that we had the bolus of support that we now have. And what we can say is that risk factors over the life course, really, whether it be early, mid, or later life, increasingly suggest that what you do with your brain and your body really matters to your later life risk. And so you can see this, and we can talk more about that in the breakout room. I'm going to focus on physical activity, which has been the most widely studied of the risk factors for modifiable risk factors. And one of our small studies within the experience core was kind of a baseline study that kind of attempted to use objective physical activity measures. And at that time, that was a little bit novel as well. And so what we were kind of looking at is this idea of how do we go beyond thinking about moderate to vigorous activity and think about what it means to be active at a low level of intensity, just getting out of bed, moving, having somewhere to go every day. Would that help? And if we could demonstrate that a few increasing just a little bit more activity each day was beneficial, maybe we could persuade reviewers, grant reviewers, that doing something like a volunteer program that didn't target physical activity per se, perhaps there's still some degree of physical activity that is occurring that could be beneficial to the brain. So this is one study among two. I cite two studies that support the idea that even small increases cross-sectionally, in this case before the trial, in daily activity are beneficial to both the hippocampus, which is important to memory, and a particular subregion of the hippocampus that's important to spatial navigation. So our work is suggesting a very functionally precise mechanism through which small differences in lifestyle activity, walking activity might actually be good. You know, maybe we can meet people where they are in their sedentary behavior and get them out of their house. And so that kind of speaks to where we are today in our guidelines for physical activity. And those guidelines have yet not changed much. I see Amal is on the call, on the Zoom, and he's more expert in this than I am, along with Jen. And I think that what we know is that these guidelines were developed, using guidelines that may be perhaps outdated. But the more important point for me to make today is that it really may be hard that people know this is good for them, but it may be that there are many structural barriers that prohibit people from being able to adhere to these guidelines. And so I show you two pictures that were taken in Baltimore, one at a local facility that's nicer than the Y, but fairly common. And then the other one right behind the Center on Aging and Health. And actually, that's a pretty nice block, but many of the blocks, they can be sketchy, and they do change as a matter within even really a 3-block radius. You have to be careful about where you're walking and keep your head up. So the idea here is that we want to try to give older adults the prescription we think they need, but we need to think about the environments in which they live. And we also need to think about who needs to be targeted. If we're talking to the worried well who already have access to a lot of resources, that's fine, but it may only be bumping them up just a titch. Whereas we're kind of thinking about those people who are in their homes and they're sedentary and they have nowhere to go and no reason to get, no purpose. So here's where the experience core model really steps in. And in 1999, when we first started the Baltimore-based studies and trials, we really had this premise together, and it'd be Tanner's on the call. I don't think Janine's on the call today, and of course, George. And let me know if there are others here in our group that started with us on this long, really productive road. But what we understood at the beginning and baked into the experience core model was that what older adults do affects their health, that remaining relevant and engaged really doesn't change over the life course. Developmentally, it's always with you. You want to be purposeful even in retirement, especially after retirement. And that teaching children during a critical life window could provide a win-win, where the growing child is developing neuronally at an accelerated pace. The older adult is being depleted of resources and opportunities through retirement, perhaps the movement of their children, and the aging and perhaps disability of their friends and their social networks. So we felt like this is a win-win in giving children some social support and giving older adults social support. So both ends of the life course could benefit. This is, many of you know these, and Chin Lee is on the call, I assume. So Chin Lee, and so we know all of these premises, and I'll briefly say that really essentially volunteering is meant to move the body, cognitively engage people, and also socially engage them in a network with purpose. So in the Experience Core program, these were the tenets, and then they had multiple roles that we trained them on over the course of a 30-hour training program. And then the different components of those engagement properties are listed here, such as just traveling to and from school, going into the schools, going up the stairs. They didn't have elevators. And then even getting in and out of the little chairs. If you do that a few times, you will find your quads actually get exercised by getting in and out of those chairs. So in 2006, a large-scale trial was funded, and over 4 years of randomization, we obtained data from 702 older adults, half of whom went into experience corps, committing for 2 years, and half of whom were referred to a low activity kind of volunteer patrol opportunity. They were placed in up to 25 public elementary schools in groups of about approximately 10 to 15 or so. And we looked at a number of outcomes spanning the whole body and brain and cognition. And so in the interest of time, and I welcome you to go to our website or my lab website. I think we don't yet have an experience course site that posts all the papers, but the Carlson lab site I think does. And so what we do is we look at a number of these outcomes, and when looking at them, the original cohort is a group that is just by demographics naturally at risk for a number of adverse health outcomes, including disability, dementia, and mortality. And you can see here the mean age is actually not that old, 67, but 85% were female, which is a risk factor for disability and dementia. They were 90% African American, which is a risk factor. And their mini mentals were not actually they weren't at 30, which is what we often see in volunteer studies. Their education levels, again, another risk factor, with more than half not receiving a greater than high school education. And then if you look at their medical comorbidities, we see a high degree of diabetes and hypertension. The observed intervention specific and dose dependent benefits I summarize here. I have a whole talk on that, and George does too. But again, I think the point for our next efforts in this long-term follow-up was to demonstrate that we observed many small benefits across all of the outcomes that we were looking at. So for psychosocial outcomes, Tara Grunewald led a study looking at generative desire, generative achievement, and showed using a nice complier average characteristic modeling. I think Chinley is the expert who guided us through that. And Tara did a beautiful job of showing that there were dose-dependent associations between being an experience corps volunteer and showing generative value. For lifestyle, Janine Parisi led a paper looking at the effects of the program on trial outcomes, independent of anything else, pre and post exposure. So it wasn't related to what they were doing in the program, it was related to lifestyle activity outside of the program. And that was important to show we were not trading activity, like people didn't go home and just crash on the couch after participating. We have data on mobility, and that's occurring more using the objective measures of the physical activity measures. And then we have data on the brain benefits and the cognitive benefits with regard to memory. So in sum, there is evidence for multiple benefits, modest benefits, some being stronger for men than women. And so we didn't predict that necessarily, but those are areas that we can explore further. Overall, given these modest benefits across multiple outcomes, we do find that being a volunteer seems to be good for the individual, and we don't know the mechanism. We don't know if it's physical activity, cognitive, or social, but at some level, maybe it doesn't matter. If we're demonstrating benefits, we can perhaps figure some things out later. The challenge that kind of brings me to the study is the scaling up. We've spent, and in my particular history, I served on a nonprofit that helped scale up the experience corps locally and nationally with AARP. And it's still, even under the large, considerable resources of AARP, there were challenges, and these challenges have to be recognized. And among those challenges that we consistently understood to be problematic was cost effectiveness. That really, to sell this at a local level, everybody that we know would like an experience corps program, but you need to have the resources, and that's not an insignificant problem, because it requires people knowing how to tap into resources, how you cobble them together. And one way to address that is to get federal funding, for example. So I think about Sarah Zanton's Capable program, where she immediately demonstrated cost effectiveness in the northern part of the country, and was able to put work with the state to get funding on a large scale. And I think for us, that's where we are today with this, the long-term follow-up is trying to help us understand whether or not experience corps had long-term effects that might actually be cost effective. I list the other challenges here, really just more food for thought and maybe fuel for our breakout. And here are the aims of the long-term follow-up. that what we're doing is we're using linked Medicare and Medicaid, as it turns out, given our recent updated efforts. So Medicare, Medicaid, Maryland CRISP data, which is probably an underused resource in the state, and it's unique to Maryland, and National Death Index data. So collectively, these linkage data sources will allow us to determine whether or not they're basically three coupled outcomes, whether or not participating in Experience Core versus being in the control group was related to a shorter duration of dementia and Alzheimer's disease, and associated health care costs relative to controls. And for maximal specificity and sensitivity, we're also obtaining telephone interviews where possible. So we contact the older adults, and I sympathize with the issue about time since follow-up. We're at least 10 years out from having last talked to most of our participants. So it's almost like a cold call. And we are, that is very challenging for a number of reasons we can talk about. And then aim 2 is really looking at whether or not the same exposure was related to better long-term independent function, and again, lower costs in the healthcare system relative to the control group. And the third aim is whether or not they had a better quality of life using data, again, that are readily available through the linkage data. And the last being, is there a lower risk of mortality among former Experience Core participants? So we have essentially those really 4 linked outcomes. And when I think about where we're going from here, again, I want to come back to the environment. And I want to share with you some data that we collected at baseline in Experience Core participants, regardless of their intervention status. And I think what's important to share is that we need interventions that target people who may not have resources in order to, in which to go and find their own programs. And so here I show you a heat map of participants in the larger trial, the group of 702 at baseline based on their residential location in Baltimore. You see they're spread out across the city, with Charles Street being the dividing line between West and East Baltimore. And what we show, the heat map shows that the darker orange areas are people in which there was a density of participants for whom they had poor cognition, both poor global cognition and poor memory scores. And these individuals, I propose, are the individuals who will stand to benefit most from Experience Core because of the lack of opportunities in their communities. So these are some guiding principles, and in the interest of time, again, I'll kind of have you read them, but this is, sort of my guiding principle in terms of the way I approach Experience Core, and thinking about our hope that, given what we've shown, the long-term outcome data that we're obtaining right now through what's called MEDRIC, a new enclave in the NIH-supported funding stream, that if we can demonstrate that these behavioral interventions have long-term benefits to healthcare costs and Medicare, we believe this might be a means by which to really expand this program beyond the realm of which it has been able to expand so far. And AARP is very interested in this as well. And of course, it takes a village, and this is our research team, some of whom are on the call today. Thanks.
Thank you, Michelle. Really a great talk and another amazing study. And thank you so much for leading the follow-up and all your leadership throughout the Experience Core trial and follow-up. So I think, in the interest of time, unless anyone has I see Betsy has in the chat, thanks for addressing safe spaces. Virtual in-group activity helps for low-income resource areas, and your work definitely promotes and supports age-friendly community model for cities like Baltimore, thus an intergenerational approach. So did you want to comment on that, Michelle? I think it's a great point, Betsy. Yeah, wonderful point. I think, in the interest of time, we'll kind of hold off on the questions and go right to the breakout room. I'm going to pause the recording